HealthIMPACT Live September Forum. We've changed our cadence for our virtual events, and as we are beginning to meet in person again, we are excited to continue to connect online on this, the third Thursday of every month, with healthcare leaders making an impact. Today, I'm joined by my colleague, Janae Sharp, founder of the Sharp Index, and our resident physician burnout expert, and we continue our discussion of healing our nation's healthcare system. First up, we are excited to be here with Theresa Brown. Theresa has her PhD in English and her BSN and RN, and as such, is both a prolific and engaging author and an oncology nurse. I had the pleasure of meeting Theresa back in 2018, which seems like almost a decade ago now.
Yeah.
And at the time, she had just released her New York Times bestselling book, The Shift, One Nurse, 12 Hours, 4 Patients' Lives. And I'm delighted to be here to discuss her soon-to-be bestseller, Healing, When a Nurse Becomes a Patient, where Theresa shares her story as a nurse diagnosed with cancer. I just finished it, and there was just so many aha moments and I hear you moments that I'm just thrilled to be talking about it. Theresa brings us along her journey from the mammogram through the diagnosis, treatment, and recovery. And today we're going to talk about the surprises, the disappointments, and what we as healthcare leaders can do to be better at healing. Theresa, I'm so excited to have you here today. Tell us a little bit about the book and, about what you've been up to.
Yeah, well, first, Megan, it's great to be talking with you again. It's always really a pleasure. So thanks for that. Yeah, the book came out of my experiences suddenly becoming a breast cancer patient. And as I say in Healing, I thought I knew cancer, right? I knew what it was like to get a cancer diagnosis because I'd taken care of so many people who'd been diagnosed with cancer. And then the reality is, no, really, when it's your cancer, it's completely different. And all of a sudden, there's a question of, do I have cancer? It looks like I have cancer. And yeah, I have cancer. And it was absolutely terrifying. I mean, it's a scary word and a scary diagnosis. And so that first awareness of, wow, I thought because I was a nurse, I knew what this was like, ended up being a process that happened over and over and over again during my treatment, where when there were glitches or people didn't come through for me, or people were just unkind or kind of profoundly dismissive of the importance of, what was going on with me, I thought back on moments as a nurse where I'd had patients have similar kind of experiences, and suddenly I saw this whole tableau of sort of suffering and pain that hadn't been seen, and compassion that hadn't been delivered. Right. And that's what got me to write the book, was to say, hey, we do not know what patients are going through, and we are not meeting them where they are a lot of the time. And that's actually why the book goes back and forth between, here's a treatment moment, and then here's a moment where I'm remembering being a nurse, because that was the constant juggling that was going on in my mind, trying to make peace with failures on my part that I didn't see that way at the time. I did not understand it at the time that, well, I really let someone very vulnerable, I let them down.
Right. Mm-hmm. We've had a few conversations with, healthcare leaders who have become patients, within their own systems, and that experience. I think just last year we talked to Pamela Aurora, who was the CIO at Texas Children's and had breast cancer, and just, that the perspective on patient experience changes.
It's totally different. Yeah. Theresa, oh, sorry. Do you want? Well, I wanted to say that I'm glad that you survived. I'm glad you're here. And
thank you. Yeah, and a couple of the talks for the book, I said, spoiler alert, I live.
I mean, it's good to know. I like to know the end from the beginning. I also wanted to, you talk about how like assembly lines are easy, which, questionable, but like, just kidding. But compassionate care is hard. And I agree with that. And I also wanted to talk about that more. Like, what did you're saying you kind of juxtapose the two, talking about memories, like what does that mean for compassionate care? Like, why is it hard?
Right. Yeah. Yeah. And assembly lines may be hard. What the image I get is
Repetitive injury is real, but it
right.
is easier if you know the motions, like you can do them, right?
Right. It's more the idea that I want the public to understand that there's not just one healthcare assembly line. There's many, many, many healthcare assembly lines. There's the we need to get you to your CT scan. There's the billing assembly line. There's the transport assembly line, right? Whereas if the patient isn't ready, they're going to leave and then they don't get their scan. And then there's all kinds of things that happen as a result of that. I mean, there's the medication delivery assembly line. And if that slows down, the person's really important medication can be delayed and there can be bad things as a result of that. So there's all these assembly lines. And then billing and profit is so important to so many of them. And because everyone's overworked, and since COVID, that's been worse and been shown to be worse kind of all over the country, right? Everyone's overworked, often are short-staffed. And in that kind of situation, when there isn't enough of you to go around and you have this constant pressure, like, I've got to move things along, I've got to keep things moving, it's very hard to stop in that moment and say, oh my gosh, why are you having a hard time getting ready for the transporter? Can we talk for 5 minutes? Can I sit? Can I help you? What can I do? And conversely, if you're the patient who says, if I don't get this medication, I'm not going to leave on time. And then this is going to happen. And that's going to happen. That's going to happen. It's very easy to say, that's not my problem. I can't do anything about that. I can call 10 times. I can't make things happen. It just is very hard to make time for people to be human beings because there's so much pressure on clinical staff. And that starts with housekeepers and goes all the way up to physicians. I mean, everyone working in healthcare feels this. And it's so hard then to stop and say, the person in this bed is a vulnerable human being. For all I know, this is the worst moment of their life. And I need to open my heart a little bit to them. And there just isn't space to do that a lot of the time. I think people want to do that, but they're just not able to.
And there's no doubt that every single person, from the housekeeper to the, physician, went into healthcare because they had that empathy,
Yes.
I mean, I know, certainly even from IT perspective, they could work in finance, but they're choosing healthcare because it's something they care about. And we've talked with Wendy Dean about the moral injury that's there, that, you make that decision and then it becomes, because of efficiency, it becomes hard to deliver on the empathy, which is so important. But I think you really touch on that nicely. And you talked about a story where, maybe you had a renewed empathy as a patient for a diabetes patient. Tell us about that, where the surgery was postponed and why,
the audience needs to hear it. I also think it's very relatable. Like this whole time is
good. Yeah. So
overscheduled a little bit. It's,
Yeah. So I had a patient who, I'm not sure how she ended up on our floor. She didn't have cancer. But it might have been that they, the floor she should have been on was, or ideally would have been on, was full. So they put her on our floor. Anyway, woman on our floor, she had very serious diabetes. She was a Black woman, somewhat overweight. And she was scheduled to have on both legs what's called a below the knee amputation. So you heard that right. She was having the bottoms of both her legs amputated. And she was there and she was having the amputation because of her diabetes, she's gotten very severe ulcerations on her legs and they weren't healing and weren't going to be taken care of. So there were kind of two issues. One, for me was there was a question of how we were supposed to treat the bandages, and there weren't orders to change them. And so I didn't change them. And then it was a floor where there was a lot of nurse bullying. Some of the nurses sort of were whispering about me behind my back and telling me I wasn't doing things right, which, was hard for me, right? This will be important. But what ended up happening with her, I had her for 2 days in a row. She was supposed to go to the surgery, and the operating room kept calling and postponing. And I was still a pretty new nurse. So, I would have called and said, what is going on? This woman needs to come in. Here's what's happening. Her family took the day off, and tried to push really hard. But at that time, I didn't know I could do that. So I didn't push, kept getting postponed. Then finally, we're doing the surgery tomorrow. No one even came and told her to her face. I had to tell her. Her adult children, like I said, had taken the day off work to be there with her. Who knows if they were going to be able to do that the next day. And so here's this woman, right? She's gone to the hospital. She's going to leave in a wheelchair. She is never going to be able to stand on her own 2 legs again. And they postpone her surgery, and they don't even tell her why. And there was a doctor in training, a resident on the case. And I went up to the nurse's station and saw him, and I was really angry. And I don't remember what I said, but I know it was something that was not kind about how could they just postpone her surgery like that. And he kind of didn't react. And then I turned around, message delivered, right? And turned around, went back up the hall, and sort of out of the corner of my eye, I saw him stand up. There was another resident sitting next to him, turn and say, don't they know I didn't want to postpone that surgery? And it was, I'm getting chills. In that moment, I suddenly saw, wow, I so completely misunderstood. And I'd taken this idea, that I was being bullied. So I thought, I'm the only righteous person here. I'm the only person here who really has any kind of moral authority, which is bunk and terrible. But once I became a patient and looked back on that episode too, it hit me. This is a Black woman, diabetic. Was the postponement of her surgery something to do with racism? Did she feel that way? Did her kids feel that way? Is that why no one came and told her to her face? Or did people not have any idea what her race and her issues were? And nobody cared enough to say, here's this woman who's going to end up crippled right after this surgery and need huge rehab, and her whole life is going to be changed, and we can't even come and tell her to her face. Right. Or where there's a whole series of emergencies and no one told me that. I don't think that's what happened, because then they would have said something. And so just having been a patient, I just saw that the callousness went so deep, right. And I think as a nurse, I was kind of blinded to like blinders, like a horse, right? Like blinders, mm-hmm. and also focused on the good we did, right? Okay, surgery's delayed. That's terrible. They handled it badly, but it will happen tomorrow. Not thinking that there's, for her and her kids, this emotional sequelae to just being treated like a body in the bed who doesn't deserve even a thimbleful of respect.
Right. Which is, I think that empathy, and a little bit in that, just talking, the transparency and the communication. And I think that that's actually come up quite a bit from, when leaders become patients in their own health system, right? And they know that they're getting the best treatment. These are their colleagues treating them. They're telling them they know they can handle some of the information that maybe other patients have that that maybe can't, or that we've sort of, in a rather paternalistic way, decided that they can't. Right.
Right.
So having that transparency and, and empathy, even if it wasn't about, inherent racism that might have been happening, or, who's insured and who's not, and various things, that the assumption that they would feel that way, or to address it without, sort of sweeping under a rug, would help everybody, because they would feel more heard. Right.
Right.
Yeah.
And right. That, and to make clear to people, we did during COVID hear a lot about racial disparities in healthcare. And definitely in writing Healing, I looked into this and put some of the research in the book that there's a huge survival gap in terms of cancer among white and Black Americans. I think we know that infant mortality or maternal mortality rates in the US are terrible now. They're much worse for Black and brown women. So the reality of Black patients not getting the same care that white patients do is absolutely true.
Mhm.
And I mean, I'm just thinking for this family, it must just eat away at them, right? Like, is this because we're Black? And if every person who's not white or straight or, whatever category they fall into is wondering, am I not getting good care because of this? Am I being treated like I'm less than human because of this? It's terribly wounding, and we're supposed to be healing people.
Right. I also think that story highlights this isolation, too. Like you're looking at it and saying, you felt like you were the only one there to stand up for the patient, and then the other physician saying something triggered realization in you. So I wonder, what that means for leadership, but also that must be really tough, really isolating.
Yeah, and
yes, also
Yeah, and you must know this from your work on physician burnout. There's so much pressure, and I hate to use the word silos, but because it's so overused, but I think it applies in this case. There is the nurse silo and the doctor silo,
right.
And there's so much pressure to keep us separate, instead of, when I wrote about issues with COVID, I tried to always acknowledge that doctors were going through a lot of the same things as nurses. I mean, it may manifest differently, it may be felt differently, but a lot of the same issues. And even now, there's a lot of physician burnout, there's a lot of nurse burnout. Both groups are, working short a lot. I mean, I try to talk about that the physician suicide rate is through the roof, which I know is something you also know about. I mean, through the roof in terms of a professional group.
It's not helpful. And also,
right.
It's interesting from an advocacy standpoint too, because you were standing up for the patient, and I've certainly been there where you're fighting so hard to be heard, you forget that people are alongside you and you shouldn't be competing. So I thought that was a really valuable insight for people. Organizations come and ask for solutions, what should we do? So I wonder how I've had to have that reminder, and I wonder how healthcare systems can do that too.
Wow, you just said that so beautifully. That should be on a cross stitch, really. You're fighting so hard, you forget there are people next to you. And I really think if the two groups could do more things in common, see each other as colleagues. So one thing to do is whatever is possible to break down the hierarchy, but also to teach mutual respect, which I think is hard. And I think for nurses and doctors, it really has to start in school, because in nursing school, we learn truly almost nothing about working with physicians, and physicians learn almost nothing about working with nurses. And then
you don't piss off the nurses. You learn that.
Okay, right. Right.
But then they know more than you.
You put these groups together, and this is how healthcare happens, is these two groups who know nothing about each other except for anecdotes, or don't make the nurses mad, or and that's how we make healthcare, right? And so, I mean, even things like every month we got a new batch of residents. I just felt like, why can't we get an email with their names and a little something about them? You know, why can't they get a list of the nurses on the floor? I mean, it's a lot of nurses, but you know, then they could have a kind of cheat sheet to sort of like figure out who am I talking to?
It goes back I mean, to the discussion around the assembly line, right? And that silo, right? Because as you said, there's many assembly lines happening, right? And so these paths that are happening, and that, you know, everybody has their job and they stay in their lane. And if you jump out of your lane or you try to change it, then you know, the assembly line stops working, or at least that's what the perception is. And so how do you make it so, you know, that everybody is working as a coordinated care team, you know, and we hear that so much, you know, and what, you know, what will support that. And I think, you know, so much of what you talk about as, you know, kind of coming in and being the patient that people want to get good care, to deliver, you know, as a nurse come in and said, you know, I know that the squeaky wheel, or the person who's, you know, maybe they get what they want, but they don't get necessarily the best experience. But so talk about that a little bit in terms of what that means, and what organizations really should be doing to both support, I mean, because that's engagement, right? I mean, we call it squeaky wheel, but engagement is a patient who is engaged and cares about the care path, and they want to be educated. So let's talk a little bit about that.
Yeah, that's a great question. One more thought, Janai, what to tell organizations to do: include nurses on morning rounds, make the nurses part of the team in that very immediate, practical, physical way. Bam. Okay.
Okay. Yeah.
Yeah, your question about, right, how do you advocate for yourself, and how does the system respond to that? And this was my main lesson. So as a nurse, and nurses and doctors, there are certain patients we label, I hate to say, difficult patients. And these are the patients, right, who are quote
not
unquote,
as a patient, but
quote unquote demanding. And I tried to be the easy patient, because I know about these assembly lines, and I know the more you kind of go along to get along, the easier it is for everyone else. And in a lot of ways, probably the better care you get, because you're not pressing on any of those pressure points, right? Those time pressure points. You're letting things happen when they happen. You're letting people go on their schedule.
To be understanding.
Right. And then at some point, I just got sick of that. And I felt like this is not working for me, and started pushing, right? And I had this moment where I realized, oh my God, I am the difficult patient. And I was like, I honestly felt incredibly embarrassed. And then I just thought, okay, that's the way it is, you know, and
You're the best difficult patient they've had in a while.
Yeah. But it just, yeah. And just because I said things like, I don't understand, why is that going to take 2 weeks? You know, no, I'm not going to wait 2.5 hours for my appointment because the doctor's other office closed and you just moved all her appointments to today. You know, just, and I mean, that actually happened. And they kind of looked not even appalled that I left, but just amazed, like, you're just leaving? Like, yes, I've been here for 2.5 hours because you've scheduled 5 people for every one appointment, you know, or whatever the reality was. But and I have to be somewhere. I have a life. Imagine that. Which sometimes you do have to wait, and it can be for a very good reason. To me, this was not a good reason, and they could have handled it in a more upfront way. So,
right.
Yeah, just to make that clear. Like, if there's been a bunch of emergencies and you have to wait, sometimes that happens. So
you're doing it again, where you're like trying to understand. Like, I think that's
well, because I also will hear
patients, right?
I'll also hear people say, yeah, I had to wait 15 minutes. Can you believe that? And I just feel like I have no patience with that either, because it's a complicated system with.
Right.
So
it's interesting too. thinking about how you're saying, like, you don't always know the people, like give people a sheet to remind them. And even when you do understand their work, like you did understand a lot of what nurses are doing. It sounds like you still had a completely different perspective after going through it. And I think that's interesting to notice. Like, we assume we know a lot, or we assume we don't know anything. You can educate so much, but certain parts of empathy you have to learn through experience. So I wonder kind of what you took away from that, like,
Yeah, well, I think the most sobering experience like that was when I really thought about the bone marrow transplant patients I took care of. And for people who don't know, these are really the sickest cancer patients. And I think people know more than they used to, because, Robin Givens had a bone marrow transplant. I mean, there's some celebrities who've had bone marrow transplants, and everyone knows Jeff Bridges went through this terrible chemotherapy and was immune suppressed. So it's kind of a sense of what it's like working with those patients. But when we say they're incredibly sick, it means they're incredibly physiologically vulnerable. They can get sick really easily. It's easy for a lot of things to go wrong. We're giving them really toxic drugs that can hurt them. And all that stuff and then they lose their hair and they get nerve pain in their fingers and their toes, and vomit all the time, and all these things happen, and nobody can come to work every single day feeling that pain, right? That's not possible to feel that and keep doing the job. But there's a kind of illusion that I realize happens where I would look at patients suffering and say, well, we're saving their life. We're saving their life, we're saving their life, we're saving their life. Which was true a lot of the time. We were saving their life. But that to me was also a way of looking away, of not seeing everything they were going through. So
Right.
how do you get that balance?
Well, and you
right?
mentioned in the book too about how healthcare workers, think that they're invulnerable, right? So if you're coming to it from a place of invulnerability, in some ways, like you said, because you're protecting yourself from that on a daily basis, from that pain of the patient. There's a level to which you can't be completely empathetic, or else you wouldn't be able to get up and work every day. So there's finding that balance, and how can an organization, support that, and I think that's I think that's a conversation that's being had, but I'd love to hear your thoughts on how, whether it's mental health. We kind of joke sometimes it's not yoga classes, it's not teaching physicians, sort of wellness.
More yoga, let's be honest.
Yeah, right. No, I've had nurses say that to me. I joke about it too. I don't want a yoga class. I don't want a meditation app. I don't want to hear someone talk to me about imagining I'm walking through a forest. These are the things,
all these things in therapy. I want more of all of them and a better work. That's what I always tell people. I'm like, I'll take yoga and staffing.
Right. So what I heard during COVID was we want better mental health care. Which is a complete sea change for nurses, like actually to admit, wow, I could have emotional issues that would help me to talk to a professional about, and I'm even talking about that and seeking it out. So that's wonderful. So that's a baseline, right? Yeah. Everyone needs access to good mental health care and a schedule that would allow them to do that in a regular way. That's a basic. But I would say also, we have so little space to be human on the job. And Megan, you and I were talking about 12-hour shifts, and it is just go, 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 go. I mean, we're supposed to have half an hour for lunch. It never happens. There's just no time to rest and think. If a patient of yours dies, you're expected to just keep going. And so some way of creating that space would be great, that could be done in a caring way, that feels loving, and like it's really appropriate to look out for each other and for staff, and to acknowledge that things are hard, which is a big, big change for healthcare. Because I hate to use the word macho, but there is kind of a macho healthcare culture, and women can absorb that just as much as men. And so for those of us doing the work, to not put that expectations on ourselves or our coworkers, and then for the institution to really support people. I mean, the experience I had as a pretty new nurse, which I ended up writing about, and that actually started my whole writing career, was I was just a couple weeks off orientation, had a patient, was going to go home that afternoon, start coughing up blood, and died. I mean, it was almost that fast. I was in the room with her, called the code. No one even said anything to me. I mean, the next day, my manager came up and said, I think it's just so good this happened at here rather than at home. And that was all she said to me, like, oh, okay, not only did I have this terrible experience, but now I have to be glad about it because I spared her family. And I mean, that experience haunted me for years, and just have talked about it so much. And I know almost everyone in healthcare has an experience like that.
Right.
And there was a resident there with me, and I actually saw him a year later, and went up to him and said, hey, do you remember this? He said, yeah, I just put that out of my mind. We kind of had this moment of mutual recognition of what we'd each been through, and then we both looked away.
So the moments of mutual recognition, have you seen people do that well? Like,
yeah,
I haven't read the book, to be fair. Megan has. Like, does it also talk about like the shared, moment of looking at it and then looking away? Or
I think the shift does more about that. Because
why don't you tell us about it?
Yeah, I mean, those are great moments when you realize someone you're working with is seeing the same things that you are, or as a patient seeing you. So at my initial, it was a follow-up mammogram and ultrasound, but that's where I got the diagnosis. And the radiologist I thought was very good, but it was the tech who, I started crying, came into the room and put her arms around me and said, we can cure this. You can survive this. And just started talking to me about their genetic treatments now, and saying all this stuff. And it was really like balm to my soul. And then she took me around and took me to see the radiologist and look at the imaging. And then when I left, she gave me a psalm that I am so regretful that I don't know what happened to that. I had a lot on my mind, but that was amazing. And that's setting a very high bar, right? I'm not saying that has to be the bar. Well, that's true. Is it? That's true. You're right. But
it shouldn't be, right? I mean, at least at that moment, right? I mean, that is the worst day potentially of your life, and so it should be something that they are prepared. And I get it, obviously, in an emergency room and in certain settings, it becomes more difficult, but I do think that's the right bar in some ways,
Yeah, and they wanted another mammogram. So they sat me in the hallway and I'm crying, like no protection from these other women waiting for their mammograms. Like, I'm not protected from them. They're not protected from me. Did this mammogram, cried through the whole mammogram. The tech never said a single word to me, except at the end, she said, I hope everything works out. So I guess when I say that doesn't have to be the bar, I'm just feeling like my God, they're just like, please do not put someone who's crying because she has just been told she has breast cancer in a hallway with a bunch of other women who are waiting. Like, that's so terrible. Why would you do that?
Right.
But of
Some
course,
people are
they
bad
would
at
say-
feelings, real bad.
Yeah. So so this incredible level of thoughtlessness, or people, oh, I don't know what to say. Like, come on, you're a mammogram tech. Like, you should think about it.
Right.
Have something
But
to
this,
say.
you know, in some ways, and the system is designed, you know, in such a way that's not built into the system,
Right.
like to protect for
Right.
that. And it should be. And I do think, you know, in our conversations, we hear more about people thinking that way, right? I mean, I think the discussion of humans, you know, patient-centered care and human-centered care at least is beginning to get to that, right? Where, you know, before, certainly the way healthcare systems are designed, they're just not, you know, where there's this, you know, maybe if you're lucky, a small curtain between you and the person next to you.
Right.
So, but it is.
Well, yeah. And in healing, I talk about going to radiation oncology, where it was so human and there was so much compassion, and it was really small things. The secretary was really nice. They let me sit out in the hallway because I didn't like being in a room with a TV on. They always knew my name. How you doing, Theresa? I mean, just with every single interaction I had there made me feel like a human being who was going through something hard, and they were going to help me with it. Right. And it's not like they held my hand or they gave me special food or they rubbed my feet or, you know, whatever.
Those would be nice too.
It would have, but I'm not saying, you know, I would reject that stuff. There. But the point is, it was politeness, civility, and recognition that this is a person who is here for our help, who needs our help, and we need to give that.
Right. So that recognition is really important. Can you tell us what's next? What book comes next?
Yeah, well, I recently made the difficult and painful decision not to return to clinical work. And it's really because of all the systemic problems in healthcare and what I saw happen to nursing during COVID, and then what I saw as a patient. It just would be so hard for me to go in and look at all these ways that we're failing people. I don't think I have that ability anymore to say, okay, I can live with that. Okay, that's fine. And, you know, you can call that burnout or moral distress or compassion fatigue or whatever you want, but it feels terrible. Like I can't do this anymore. And I love this job. But on the other hand, I am thinking about the next book, trying to figure that out, and talking to great people like you guys and doing more writing. And so I'm making my way.
And telling your story and telling your perspective as eloquently and wonderfully as you do, you know, will take us a long way, I think. I mean, you know, I certainly learned a lot from both books, and you know, I think that everybody can. So I strongly recommend they go out and get healing. As it, you know, both healed me from a perspective of just thinking, you know, because it made me think about that. And you know, I think we all have felt, you know, frustrated with healthcare at times, and also, you know, that's why we're in it, to change it and make it better and make sure for the patients it gets better. So, but thank you so much for your work and everything that you do.
Also, I think it's very important to say, like, someone told me, I talked to a lot of people about physician mental health and nurse, and some things you love, you have to let go. And so thank you for sharing that. Like, and I think things can get better. Like when people identify, look, I can't look away anymore. Like you shouldn't have to look away. And I'm sorry that was taken from you.
Oh, thank you. Yeah. And if people want to know more, I do have a website, theresabrownrn.com. And I have a newsletter on Substack where I'm talking about these issues. And I'm always interested in what other people think and have to say.
Yeah. And maybe they'll fix them so you can go back, right? Like that could happen. Okay.
That's what I want. Compassion revolution.
was like, fix it,
Well,
okay?
I love that.
Yeah.
Like,
I love that. And I think that that's, that's sort of what we're hearing it, and we're hearing it from folks that maybe aren't even, that we wouldn't expect to. So, and I think that both, for our healthcare workers and for the patients and sort of meeting that in the middle to deliver
Yay.
on that.
Yeah.
So
so
I hope you'll join us. The audience has questions. They can ask them both in the chat, and we'll join later for a roundtable. And I hope you can be there, and we'll talk with them. So thanks again. And
You're welcome.
we will definitely chat soon.
Okay.
I'm excited to see what's next.
Thank you.